have more recently gotten interested in suicide prevention at the macro level, and we'll be talking a bit about that today. And we'd also welcome you to go to our website. Some of the things that I'll be talking about are there, copies of slides and things like that if you're interested. I'm going to be talking about the smaller circles here. Much of what we're interested in doing, we would like to do, as Jared was saying, is to replicate the motor vehicle accident story. Motor vehicle fatalities have fallen by 35 or 40% in recent decades, while the suicide rate has changed very little. And we'd like to sort of work at the population level on this problem and try to do something like that for suicide. And that involves reducing stigma and gatekeeper training and helping people with help-seeking kinds of behavior. We want to encourage people to get help when they need it and help them to know how to do that. And things like means restriction. We're going to hold a conference in the spring. Our annual Aaron Bailey lecture this year will focus on means restriction, things like gun locks and packaging for pills and things like that. So there are things at the whole population level. I'm going to talk about things in the smaller circles at the health system level, and then within mental health services that would help us with suicide prevention. So I think the critical steps are identifying people at risk in a consistent way, deciding who among the people who have some risk is at the most risk and needs the most help, and doing the most to protect them. Our access points, how do you get into the system and get help, and then what kind of help is helpful, and then finally maintaining that over a long enough period of time to actually save lives. One of the things that we know very well from many studies is that primary care doctors actually see most depressed patients, not psychiatrists, not social workers, not mental health professionals generally, but primary care docs. Do they ask about suicide? No. The answer is that even when they're prescribing antidepressants for someone who is depressed, they do not detect suicide risk in those patients. This is the best numbers are from Europe. In the U.S., it's worse. So this is a group that we would like to see become better at asking the question. If you're going to treat somebody for depression, surely you should know, whether they have suicidal ideation or not. This is also true in emergency settings. If anything, it's even worse. Emergency room doctors are in a big hurry and really are reluctant to ask people about suicide, even though work that we've done suggests that if you go in, if you just ask people in the emergency room with a broken leg, 5% of them will have suicidal thoughts, and as many as 19% of them will have made a prior attempt. So by definition, they have some suicide risk. So we're doing a study now to try to identify those people and then provide them with telephonic counseling after they leave the emergency room. So these are things that we could do more of in healthcare settings. Next slide. Something that would help with that would be to all agree about what the terminology means. If you read the literature, you will see suicide referring to all kinds of different things. And we really need to get clear. There are some efforts to do this. The CDC and the VA have agreed on a common nomenclature. The Columbia Suicide Severity Rating Scale is similar. We like that. We are working on a standardized assessment, which we hope that hospitals in Colorado will use. One of the things that really frustrates me is that if you walk into an ER, any two ERs in the country with the same complaint, you're likely to get a very different kind of assessment, and that strikes me as weird. So we'd like to standardize that, and the Colorado Hospital Association is helping with that. Having gathered enough information to know whether someone is suicidal or not. We need to figure out sort of, are they low, moderate, high, and agree about those terms. And the other thing that's in some flux is training and qualifications. You might imagine that if you saw a mental health clinician, they would know a lot about suicide. That is not necessarily true. And so one of the things we need to do is provide better training on suicide prevention for mental health professionals so that they all come at it with the same degree of skill. What's the big problem, though? The big problem is probably access. This shows you the trend since 1981, and generally it was looking kind of good. You know, suicide rates were coming down in Colorado. This recent jump, I think, is partly related to the economy, as Catherine says, but it's also partly related to an erosion in mental health services. Mental health services are not as well funded today as they were 5 years ago. More people are uninsured now than ever. And so it's harder to get help once you've decided that you need it.
Is that how much more you got, Mike? Is that the last one?
No, one or two more. Here, I'll rip through it fast.
Okay.
Go ahead. So some of this, how do you get access? Really do want people to learn this number, 1-800-273-TALK. There's a new Metro crisis service also that we hope will grow. We think telehealth, telephonic counseling, those kinds of things are going to be increasingly important. A new move is the medical home. As I said, most people are treated for depression by their primary care doc. We want mental health services in those kinds of offices, including rural communities, to be better equipped to help people who are suicidal. And ultimately, we have to, I think, increase funding for mental health services. Next. What works? Medications are very helpful for people with unipolar depression, not so much for people with bipolar depression. Our work suggests that antidepressants don't help bipolar people at all and may hurt them. There are some medications that help in bipolar disorder, though. The main thing, though, is that medications only help if you take them. And so people have to be able to get the medicines, and somebody has to sort of teach them and help them to keep going. We really like psychotherapy. We think psychotherapy works when you stop psychotherapy. Medications don't work when you stop medications. So we would like more people to have access to good psychotherapies, particularly dialectical behavior therapy. And the other thing is, if you're seeing a mental health professional, we would like that person to routinely check whether you have suicidal thoughts, whether your suicidal thoughts are coming and going or not. And to appreciate, most people who kill themselves in a mental health setting were said to be low risk just before they died, because people were not actually checking their risk. And finally, we need to close gaps in the system. You may get into a hospital if you're suicidal, but then you may not be able to get into an outpatient provider when you leave the hospital. That's a really critical period. That's actually when most suicides occur in the mental health system, is between the hospital and the clinic. So we really need to tighten up the way that our system works once people are in it.
Thank you, Michael.